Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Effects of Oncologist Implicit Racial Bias in Racially Discordant Oncology Interactions by Penner et al. My name is Kevin Fasella, MD, and I am Professor and Associate Director of the Family Medicine Research at the University of Rochester Medical Center in Rochester, New York, USA. My research focuses on understanding contributors to healthcare disparities, including racial bias. There is robust scientific evidence from implicit tests and neuroimaging studies that humans harbor bias related to other people's social class, sex, age, disability, and race. None of us are immune. These biases hold for every group that has been tested, including physicians and scientists. Most biases operate under the radar of our own awareness. Often, we respond to people and situations based on an automatic, affective-laden response referred to as implicit bias. Malcolm Gladwell's popular book, Blink, is about implicit bias. When our bias is socially acceptable, it is easier for most of us to acknowledge its presence. However, when our bias is related to a sensitive and charged topic such as race, most of us become uncomfortable. None of us want to believe we are racially biased, unconsciously or not. The publication 13 years ago of a landmark report by the Institute of Medicine, now the National Academy of Medicine, called public attention to physicians' implicit bias. This report, entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, not only documented the existence of inequalities in healthcare based on race and ethnicity, but suggested a role for implicit bias as one contributor to these healthcare disparities. Since its publication, research has shown physicians' communication patterns differ by race. Physicians tend to adopt more patient-centered, more engaging, and more interactive styles of communication with white patients, while tending to be more matter-of-fact and directive with black patients. These differences in physicians' communication by race appear to be related, at least in part, to physicians' own level of implicit racial bias. Less is known about the impact of this bias on patients themselves. In the current study, Lewis Penner and his colleagues addressed this question by studying oncology visits as part of a larger intervention study designed to improve cross-race communication. The researchers recruited 18 non-black oncologists and 112 black patients from cancer center hospitals in Detroit. All consented patients had recently confirmed cancer diagnosis involving the breast, colon, rectum, and lung, and all had impending visits for initial discussion of treatment options for their cancer. Following informed consent, oncologists completed the Implicit Association Test. This test, referred to as the IAT, is the most widely used test for implicit bias. It's been extensively validated and has been previously used to assess physician bias. Here's how it works. Participants are asked to quickly pair white and black faces with favorable and unfavorable adjectives. The speed of pairing has been shown to capture implicit bias. For example, whites generally more quickly pair white faces with the word friendly. In this study, office visits were video recorded. 2 black and 2 white trained research assistants who were blinded to the IAT results rated the visits. They rated oncologists on their informativeness, emotional supportiveness, and partnership building. Immediately following the visit, patients rated the patient-centeredness of their own visit. Patients also rated their confidence in the treatment recommended by their oncologist and how difficult they felt it would be to complete their cancer treatment. Previous research has shown that patients' confidence in physicians' recommendation and patients' perceived barriers to treatment are strongly related to their adherence. 1 week after the visit, the patients rated their difficulty in recalling what the oncologist said during the visit and also rated their own levels of distress. The results were telling. Despite these relatively low levels of bias, statistically significant associations were observed between the oncologist's implicit bias and their interactions with their Black patients. Higher bias was associated with displaying less supportive behavior and with shorter visits. Importantly, patients' reactions differed based on the implicit bias of their oncologists. Oncologists with greater bias were rated by their patients as less patient-centered. Patients of these oncologists also reported more difficulty recalling conversations with them and reported more distress following these visits. Most importantly, patients seeing these oncologists reported having less confidence in their oncologist's treatment recommendations. These patients also expected to have greater difficulty in completing their cancer treatment. These findings suggest that implicit racial bias by oncologists affects key aspects of physician communication with Black patients, and that this communication affects patients. What does this mean for oncologists? Hard research on interventions is lacking, but evidence suggests that the following can help. First, recognize that biases are part of being human. Our biases arise out of our environment and upbringing. Denying we hold bias perpetuates the problem. Second, recognize our own specific racial bias. This is not easy, but recognition is a first step towards finding ways to mitigate it. Take the IAT yourself. You can find it on a Harvard University website by Googling the term Project Implicit. The results may surprise you. Third, look at outcomes within your own practice. Do patients from majority groups experience better outcomes? Notice how your communication style differs by the patient in front of you. This requires mindfulness or awareness of how you are feeling and behaving in the moment. Reflect on patient visits immediately afterwards. Many physicians find it helpful to share their experiences with close colleagues or to keep a journal. Consider a course in physician mindfulness. Fourth, promote diversity among your colleagues and staff. Staff diversity can foster better understanding of different cultures while improving the comfort among diverse patients. Last, a patient-centered approach is helpful for all patients. However, it is particularly helpful when the patient is from a different race or ethnicity than your own. Strive for cultural humility and respectful cultural curiosity. Ask patients about their own beliefs, values, and views. Allow your patients to teach you. Research shows that the more we come to see each patient as unique, the less we rely on our own implicit biases. Be sure to acknowledge your patient's strengths and seize upon empathic opportunities. Ask patients about their own thoughts, feelings, and fears regarding proposed treatment options. Find out what patients want to do and ask them about any barriers they perceive in carrying out the plan. Engaging patients in shared decision-making improves outcomes. Asking patients about barriers allows you to partner with your patient to devise a workable plan. These steps will help you to not only become more aware of your own biases, but also provide you with a practical means for mitigating their impact on patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.